Very good morning, everyone. Dr. Hamid is here. Today we are going to talk about adrenergic agonists. In previous lecture, we talked about receptors as well as neurotransmitter, which are in adrenergic system. In this lecture, we want to know which chemicals or drug can increase releasing or it can inhibit metabolism of these neurotransmitter in the synapses or in the adrenergic fiber. As well as we want to know that which drugs or chemicals can bind to adrenergic receptor and they can stimulate the adrenergic receptor, which leads to increase in the activity of the sympathetic nervous system on target organ. The first point we should keep in our mind about adrenergic agonists is that all adrenergic agonists are derivative of this chemical structure, which is beta-phenylethylamine. Beta-phenylethylamine. This structure is common between adrenergic agonists. Now, if we see the difference between adrenergic agonists, the only difference between adrenergic agonists in their chemical structure is the number and location of hydroxyl group on benzene ring. This is benzene ring. The hydroxyl group can be here, the hydroxyl group can be here, or the hydroxyl group can be here. The first difference between adrenergic agonists is the number of this hydroxyl group. Maybe in one of the adrenergic agonists, the number of hydroxyl group is 2. But in other adrenergic agonists, the number of hydroxyl group on benzene ring can be 3. So the first difference is the number of hydroxyl group and the location which this hydroxyl group is bounded to this benzene ring. So the first difference is on hydroxyl group, number, and location. The second difference is, look at here, this is the side chain and this is the amine group of the side chain. The second difference is the nature of the substituent which binds to this amine group of the side chain of the benzene ring. So the second difference is the nature of substituent, which binds to amine group or amine group. These are the two differences between adrenergic agonists in their chemical structure. Now, imagine that if the substituent is CH3, if this substituent binds to amine group, that chemical structure or that drug will be more potent at the beta receptor. But if the substituent is CH3 2 times, the beta receptor, it shows more effect on beta receptor, but little effect on alpha receptor. Now you can see that what is common between adrenergic agonists and what is the difference between adrenergic agonists. We can classify adrenergic agonists on the basis of their chemical structure into two groups. So we'll study about the classification. We can classify them into two groups. The first group is catecholamines. If any adrenergic agonist has this group 3,4-dihydroxycatechol in their chemical structure, those are catecholamines. But if adrenergic agonists do not have this structure in their chemical structure, those are non-catecholamines. This is about the classification. In catecholamines, we have different drugs. We have adrenaline, we have noradrenaline. All we know that Other names for adrenaline and noradrenaline are epinephrine and norepinephrine. We have isoprenaline and we have dopamine. These drugs, they have 3,4-dihydroxycatechol in their chemical structure, and they are catecholamines. But non-catecholamines, they do not have this structure. For example, amphetamine, phenylephrine, and ephedrine. These are non-catecholamine. So, what are the characteristics of these drugs? Why we are classifying drugs into catecholamine and non-catecholamine? And if this structure is in their chemical structure, what type of characteristic will give this structure to catecholamines? And if this structure is not in non-catecholamine, what type of characteristic the non-catecholamine have? The characteristics of catecholamine is that they are, because they are having this structure, they are more potent. More potent. The second characteristics, they are polar, so they cannot cross blood-brain barrier. They cannot penetrate blood-brain barrier. No penetration, or no or poor penetration. Poor penetration to CNS. To CNS. These are the characteristics of catecholamines. What about non-catecholamines? They are less potent and they have good penetration to CNS. They can penetrate CNS. Penetrate to CNS. So we can see the effect of these drugs into CNS also. This was the classification of adrenergic agonists on the basis of their chemical structure. But we can classify adrenergic agonists on the basis of their mechanism of action also. All we know that some adrenergic agonists, they can increase releasing of the neurotransmitter from the presynaptic neuron. Some adrenergic agonists, they can inhibit the enzymes which metabolize the neurotransmitter in the synapses, so they can increase the concentration of those chemicals or those neurotransmitters in the synapses. And some adrenergic agonists, they can bind to the receptor on the postsynaptic neurons or presynaptic neurons. We have adrenergic receptors on the postsynaptic neurons or on the target organ, and those receptors are alpha receptors and beta receptors. For example, we are having alpha 1 receptor, this is the alpha 1. We are having alpha 2 receptor. Alpha 2 receptor can be presynaptically and it can be postsynaptically. We are having beta 1 receptor. This is the beta 1 receptor. We have beta 2 receptor and we have beta 3 receptor on lipocytes. These are the receptors: alpha 1, alpha 2, alpha 2, alpha 3, beta 1, beta 2, and beta 3. If any chemicals binds to this receptor and stimulate this receptor, we can classify those chemicals or those drugs as direct adrenergic agonist drugs. So the first class of drugs on the basis of their mechanism of action, direct adrenergic agonist. This is the first class. The second class of adrenergic agonists, do you remember we said that if any drug increase the releasing of adrenergic neurotransmitter. The first mechanism is about releasing. For example, norepinephrine. Do you remember in adrenergic neurotransmission, we explained that we have special transporter. This transporter, it uptakes the noradrenaline, and again it will reuptake the noradrenaline, and it will restore the noradrenaline into the vesicles. Or in the presynaptic neuron, we are having monoamine oxidase enzyme. This monoamine oxidase, it will metabolize the noradrenaline or norepinephrine, and it will terminate the action of norepinephrine or noradrenaline. Now, if we can inhibit this transporter, we can increase the concentration of noradrenaline in the synapses, and we can increase the effect of these neurotransmitter on the target organ. This is another mechanism of action. Another mechanism of action, the third mechanism of action, we had an enzyme in the synapses. Do you remember this enzyme? COMT. This enzyme, it breaks down the noradrenaline, it binds to the noradrenaline, and it cleaves the noradrenaline, and it terminates the action of noradrenaline. Now, if we can inhibit this enzyme by using of any drugs, we can increase concentration of norepinephrine in the synapses, so the effect of norepinephrine on the target organ will increase. These are the mechanism of action, different mechanism of action, which we can increase the effect of noradrenaline on the target organ. And the drugs which have these type of mechanism of action, those are indirect adrenergic agonists. Adrenergic agonists. This is the second class of adrenergic agonists on the basis of their mechanism of action. Now the third class, if any chemical or if any drug has both type of mechanism of action, I mean direct mechanism of action as well as indirect mechanism of action, we classify those drugs under mixed acting adrenergic agonist. Adrenergic agonist. So this was about the classification of adrenergic agonists on the basis of their mechanism of action. In direct adrenergic agonists, we are having a different group of drugs. We are having adrenaline, we are having noradrenaline, we are having isoprenaline, we are having dopamine, phenyldopam. We will talk about these drugs. Drugs which have indirect adrenergic agonist, for example, those inhibit this channel which is NET, norepinephrine transporter. For example, cocaine can inhibit this enzyme, this transporter. Another drug which can show indirect adrenergic agonist, those are inhibitor of COMT or inhibitor of MAOs. We can classify them also under indirect adrenergic agonist. And mixed acting adrenergic agonists, we'll talk about them today. Ephedrine and pseudoephedrine, ephedrine and pseudoephedrine. These are the mixed acting adrenergic agonists. Now we'll start talking about the different drugs. First, we'll start talking about the adrenaline. You can understand where we can produce adrenaline. From the name itself, we produce adrenaline in the adrenal gland. Do you remember we are having a gland on each kidney, and this gland is made of two parts. One is cortical or cortex, another one is medulla. In the medulla, we produce adrenaline, and I told you in the adrenergic neurotransmission the difference between the synthesis of noradrenaline and adrenaline, or we can say catecholamines, in the adrenal gland when we compare it to these steps when we want to produce catecholamines in the neurons, is the last step only. We convert norepinephrine or noradrenaline to epinephrine or adrenaline by the mediation of one enzyme which is N-methyltransferase. We have this enzyme in the medulla of adrenal gland, and this enzyme converts norepinephrine to epinephrine. So we produce adrenaline or epinephrine in the adrenal gland. When we activate the sympathetic nervous system, sympathetic nervous fibers innervate the adrenal gland, and those fibers causes releasing of 80% adrenaline and 20% noradrenaline. When we stimulate the adrenal gland, by stimulation of adrenal gland, we release 80% adrenaline or epinephrine, and 20% noradrenaline or norepinephrine. The adrenaline which we release from adrenal gland, it's a type of direct acting adrenergic agonist, and it can bind to all subtype of adrenergic receptor. Remember, adrenaline starts with A, so it can bind to all subtype of adrenergic receptor. Now, let me explain something. Where do we find alpha-1 receptor? Alpha-1 receptor on the postsynaptic neurons, as well as alpha-1 receptors are on the vessels. Alpha-1 receptor are on prostate gland, and alpha-1 receptors are on the eye, the vessels of the eye. Now, if we stimulate alpha-1 receptor by releasing of adrenaline, it can cause vasoconstriction. If we stimulate alpha-1 receptor on the prostate gland, it will contract the smooth muscles of prostate gland, and it will block the outflow of the urine. And if we stimulate the alpha-1 receptor on the eye, we'll have a lecture about that, and we'll talk about glaucoma and the effect of alpha-1 receptor on the eye on that lecture only. But where are alpha-2 receptors? Alpha-2 receptors are on the postsynaptic neurons as well as on the presynaptic neurons. The effect of stimulation of alpha-2 is same as alpha-1 on the postsynaptic neurons. But when we stimulate alpha-2 on the presynaptic neurons, for example, adrenaline, when it binds to alpha-2 receptor, it can inhibit releasing of adrenergic neurotransmitter in the synapses. Now, where do we have beta-1? Beta-1 is on the heart as well as on JG cell. Imagine if we stimulate the beta-1, so what will happen? What is the consequence? It will increase the heart rate, it increases the cardiac output, as well as it can increase the force of contraction. When we stimulate the beta-1 receptor on the JG cell, it increases releasing of the renin, and you know about RAS system. We'll have a lecture about RAS system also. When we stimulate the beta-2 receptors, which we have on the respiratory system, by stimulation of this receptor on the respiratory system, we can see bronchodilation, as well as we can see decrease in the releasing of histamine. We have beta-2 receptor, so this was about the airways or respiratory system. We have beta-2 receptor on the pancreas also. When we stimulate the beta-2 receptor, it decreases the releasing of insulin. We have beta-2 receptor on the liver also. When we stimulate the beta-2 receptor on the liver, it can increase glucagon as well as it can increase glycogenolysis. These are the effects. The point I have to tell you about that, beta-2 receptor on the pancreas, it can increase releasing of glucagon. And this glucagon will affect on its receptor on the liver. It will increase glycogenolysis, and it increases the glucose level in blood circulation. And when we stimulate the beta-2 receptor, which are in the lipocyte, we can increase lipolysis. These are the action of adrenaline on different receptor. One more thing which I have to tell you is about beta-2 receptor, which we have these receptors on the vessels also. When we stimulate the beta-2 receptor by adrenaline on the vessels, it can dilate the vessels. See, the action are opposite. Stimulation of alpha-1, it constricts the vessels. A stimulation of the beta-2, it dilates the vessels. And here, the effect of adrenaline on the vessels, it depends on the dose of adrenaline. When we give it in lower doses, it dilates the vessels, but when we give it in higher doses, it constricts the vessels. It is dose dependent. So these were about the action of adrenaline. The indication of adrenaline, first, we can give adrenaline for treatment of different diseases on the basis of their action. We can give adrenaline, imagine there is cardiac arrest. When we give adrenaline, this adrenaline binds to the beta-1 receptor on the heart, it stimulates the heart, it increases heart rate, it increases force of contraction, as well as it increases cardiac output. So we can give adrenaline for cardiac arrest. The second indication, we can give adrenaline for treatment of acute asthma. And this is the drug of choice for acute asthma. When we give adrenaline, it binds to beta-2 receptor on the airways, it dilates the airway, as well as it can inhibit the releasing of histamine. So we can give this drug for treatment of anaphylaxis, which is a type of hypersensitivity. And in anaphylaxis, we are having, in the pathophysiology of anaphylaxis, there is increase in the releasing of histamine, as well as there is dilatation of the vessels. Now this adrenaline, as I explained, it can inhibit or it can decrease releasing of histamine, as well as by its action on the alpha-1 receptor, it can constrict the vessels. So we can use it for treatment of anaphylaxis. And the fourth indication, we can combine this drug with anesthetic, with local anesthesia. When we combine this drug with local anesthesia, what does it do? It constricts the vessels. When it constricts the vessels, it will limit distribution of local anesthetic to different location or different organs. So the concentration of local anesthetic in the area which we want to do anesthesia will increases, and the effect and duration of action of local anesthesia will increase also. So when we give adrenaline, when we combine adrenaline with local anesthesia, it increases the effect as well as it increases the duration of action of local anesthesia. And we give this in low concentration, we give 1 to 1 lag. This is about indication of adrenaline. The next thing we should know about adrenaline, it's about pharmacokinetic of adrenaline. We can give adrenaline by IV route, we can give adrenaline by IM route, we can give adrenaline by subcutaneous route, as well as we can give adrenaline by inhalational route, and it depends on the cases, as well as if we want to see the action fast, we can give, for example, by IV route. It depends on the cases. Metabolism of adrenaline, we know now 2 enzymes which are MAO and COMT. These 2 enzymes they cleave the adrenaline. They are responsible for metabolism of adrenaline, and they convert adrenaline to different metabolites like VMA or vanillyl mandelic acid, like metanephrine, like normetanephrine, hydroxymandelic acid. These are the metabolites of noradrenaline. About excretion of adrenaline, we excrete these metabolites in the urine. Last thing about adrenaline which we should know, it's about the adverse effect of adrenaline. See, they have effect on beta receptors, so they can increase the heart rate, they can increase the cardiac output, they can cause arrhythmia, they can increase arrhythmia also. These are the cardiovascular system adverse effect. They show some adverse effect on the central nervous system. They can cause anxiety, they can cause tremor. These are the adverse effect on central nervous system. They can induce pulmonary edema as well as hyperthyroidism. These are some other effects. They can increase the glucose level, so they can cause hyperglycemia. These are the some adverse effects with adrenaline, which is a type of catecholamines and a type of direct adrenergic agonist. The next direct adrenergic agonist is noradrenaline. Okay, for simple understanding of direct acting adrenergic agonist, we can classify direct acting adrenergic agonists on the basis of their selectivity. Some of the chemicals are selective for alpha-1 receptor, and the chemicals which are selective for alpha-1 receptors are norepinephrine or noradrenaline, norepinephrine or noradrenaline, as well as phenylephrine. These are selective for alpha-1 receptor. I have explained where do we find alpha-1 receptor on the vessels. So by giving these two drugs, norepinephrine and phenylephrine, they bind to alpha-1 receptor on the vessels, and they stimulate this receptor and they cause vasoconstriction. We can use norepinephrine for treatment of different shock, especially those distributive shock, which we can see vasodilatation. This was about the drugs which are selective for alpha-1 receptor. We have drugs which are selective for alpha-2 receptor, and the drug is clonidine. This clonidine binds to alpha-2 receptor. It stimulates the alpha-2 receptor on the presynaptic neuron, and it decreases releasing of neurotransmitter, adrenergic neurotransmitter. So we can use for treatment of hypertension, as well as we can use this drug for treatment of or for decreasing the withdrawal symptom. Decreasing the withdrawal symptoms. We have drugs which are selective for beta-1 receptor, and the drug which is selective for beta-1 receptor is dobutamine, which we can use this dobutamine. Let me just explain the mechanism of action of dobutamine. It binds to beta-1 receptor, it can stimulate the heart, it increases the force of contraction, it increases the heart rate, as well as it can increase the cardiac output. So with this explanation, when do we want to increase the cardiac output? In heart failure. So we can use this dobutamine for treatment of heart failure, as well as we can use for to support the inotropic effect after surgery. We can use dobutamine also after surgery for inotropic support. This was about drugs which are selective for beta-1 receptor. We have drugs which are selective for both beta-1 as well as beta-2 receptor, beta-1 as well as beta-2 receptor, and it can stimulate both type of receptor. The drug name is isoprenaline, which is a synthetic drug, and also it's non-selective. It means that it can bind to beta-1 as well as beta-2 receptor. By binding to beta-1, it can increase force of contraction, it can increase cardiac output as well as heart rate. By binding to beta-2, it can cause vasodilatation. So we can use this drug for treatment of cardiogenic shock and septic shock. Cardiogenic shock and septic shock. We have some other drugs also, I will write them here, which are selective for beta-2 receptors only. Beta-2 selective drugs. We have short-acting drugs as well as we have long-acting drugs. You can classify these drugs into short-acting as well as long-acting. Short-acting, for example, albuterol, as well as terbutaline. We have long-acting, for example, salmeterol and formoterol. These are the long-acting beta-2 agonists. We can use albuterol, salmeterol, and formoterol for treatment of asthma. And terbutaline, we can use it as an off-label drug for uterine relaxation. It is a uterine relaxant, and we can use it for that action or that effect also. We have beta-3 selective drugs. Beta-3 selective drug, I have talked about this drug, which is mirabegron, and we can use mirabegron for treatment of overactive bladder, as well as we can use some other beta-selective drugs for treatment of obesity. We'll talk about those drugs in obesity lecture. This was about direct-acting adrenergic drugs on the basis of their selectivity. One more drug is left, which is dopamine, and another one is also phenyldopam. Dopamine and phenyldopam, they act on the dopamine receptor, but this dopamine, it can act on the alpha receptor and it can act on beta receptor also. The effect is dose dependent. Because I have not explained about the dopamine receptor, I will write dopamine receptor agonist, dopamine agonist here only, dopamine receptor agonist. We have dopamine itself, dopamine, which I told you the effect of dopamine is dose dependent. In lower doses, it stimulates the beta receptor. In higher doses, when we increase the dose, it stimulates the dopamine receptor. In higher doses, it can stimulate the alpha receptor. Now, the indication for dopamine, we can use dopamine for treatment of cardiogenic shock. And another drug which can stimulate the dopamine receptor is phenyldopam. It stimulates the D1 subtype of receptor, D1 receptor, and we can use this drug for treatment of hypertension. But we use this drug in emergency hypertension to decreasing the blood pressure. This was about the direct acting adrenergic agonist. Another groups in adrenergic agonists are indirect adrenergic agonists. Some of them can increase releasing of adrenergic neurotransmitter like amphetamine and tyramine. And some of them can inhibit the net transport or norepinephrine transporter, which is responsible for reuptaking of norepinephrine, for example, cocaine. This cocaine is a local anesthetic, but we are not using this drug or this chemical in the clinic. Another group of adrenergic agonists are mixed acting adrenergic agonists. Two drugs we have in this group, ephedrine and pseudoephedrine. Ephedrine and pseudoephedrine, they show both mechanism of action, direct mechanism of action and indirect mechanism of action. We can use ephedrine for treatment of hypotension because it stimulates the alpha receptor and it causes vasoconstriction. It can increase the blood pressure. It dilates the airways, and also when it binds to the adrenergic receptor on central nervous system, it can stimulate the central nervous system. It can decrease the fatigue, as well as another effect of this drug on central nervous system. It can improve athletic performance. These are the effect or action of ephedrine. So one more point that I have to mention about ephedrine, we excrete this ephedrine unchangedly. But pseudoephedrine, we metabolize this drug incompletely, so it has incomplete metabolism, and we can use this pseudoephedrine. We can use it for nasal and sinus congestion. Nasal and sinus congestion. This was about adrenergic agonist lecture. In this lecture, we talked about chemical structure of adrenergic agonist, classification of adrenergic agonist, and 3 different classes of adrenergic agonists on the basis of their mechanism of action: direct, indirect, and mixed acting adrenergic agonist.